is easy as apical peritonitis. The same terminology for you in your country, right? But my question is, if the boy is your patient, and if the boy came to your dental clinic, then what would you do for the treatment, for the tooth? And how many of patients do you have? We say opacification, apical barrier, and regenerative pulp surgery, right? But my next question is there any other possible available? Just think about it. We'll talk later. Now, let's move on to another case. This is an 11-year-old girl. She had no complaint of any discomfort. But the clinical examination, we could say the tooth discolored. And it turned green, right? The X-ray showed that the ulcers here, which means dilation inside the crown. And the root was mature with open apex. But the X-ray cannot tell if that reduces is the apex, right? So it cannot tell us if the pulp involved. But in the process of removing all the latent tissue, the pulp exposed, and significant pus and bleeding discharge. You see? The pus and the bleeding. So now it's confirmed that a pulp involved and the pulp is irreversible. But after all the latent tissue removed, white pulp tissue was observed just 1 or 2 millimeters beyond the exposure side. Then white pulp syrup attached to keep the whitelet in 2 visits. Then just follow up. In the next maybe, let me say, 14 months, the tooth is asymptomatic, and the X-ray showed the root continue to develop, right? And the length of the root increase, and the wall sinking, right? What does that mean? It means that white pulp surgery for this tooth with irreversible pulpitis had achieved success. Now some of you guys may be a little bit confused, right? Because it's taught for a long time, even to now, white pulp surgery indicated for tooth with normal pulp or reversible pulpitis. And only healthy tissue should be remain. Right? So, the question, how can white pulp syrup achieve success in teeth with irreversible pulpitis? Actually, we say irreversible or reversible pulpitis is diagnosis mainly based on the history, check complaint, clinical examination, and X-ray examination. So, basically, it's a clinical assessment for pulp stages, right? But it's well known that the correlation between clinical assessment and histopathology is weak. In other words, the clinical assessment cannot tell us the real status of dental pulp. And the European Society of Odontology notified in the position statement that all the techniques currently used to do the evaluation of pulp status are limited, because they cannot actually tell us the continuum of pulp inflammation and cannot determine the link between inflammatory status and the healing position of affected tissue. In other words, we just have to say the clinical evaluation cannot clearly determine whether pulpitis is reversible or irreversible. And the more important is, up to now, more and more evidence have been published to show that the teeth clinic diagnosis with irreversible pulpitis have been successfully treated with white pulp therapy. And furthermore, there are also many evidence shows teeth clinical diagnosis with apical periodontitis also have been successfully treated with pulp therapy. You say the earliest one was published in 1967. And it was about a 14 years old girl. She came to the clinic and reported, "I had a bad toothache at times, but it isn't hurting now." On clinical examination, the dentist found the amalgam restoration on the lower right first molar, and the proximal portion being lost, and the tooth had extensive decay. And the X-ray examination showed periapical involvement of both mesial and distal rows, so showing radiolucence in the peak end of both rows. So it's reasonable for us to make the diagnosis for the tooth with apical periodontitis. Right? It's reasonable. So the dentist just removes the superficial decayed dentin and seals the cavity with zinc oxide and eugenol cement, then made an appointment for what? For root canal therapy. Right? It's normal. But the girl failed to keep the appointment. Maybe just because the missed appointment, the dentist had new discoveries that are totally different from his previous understanding. Why? The girl came back 18 months later and complained the offending tooth sensitive to cold water. And the clinical examination found part of the temporary restoration had been lost. Is reasonable, right? Because it's temporary restoration. But what is not so reasonable and what is unexpected is the X-ray shows a normal picture of the periapical area. And the radiolucence in the apic of both roots disappear. And more surprising, the tooth responds at the normal level to a pulp test. Now the dentist totally puzzled. He had no idea what happened because it's It's a common belief, right? It's a common belief that apical periodontitis only develops when necrosis and infection affect the entire dental pulp. And the white pulp tissue should not and unexpected found in the canal with of the tooth with apical periodontitis. Even today, for many of our dentists now, it's a common belief, not to mention 6 years ago. But fortunately, even though the dentist is totally puzzled, he's confused, but he just did indirect pulp surgery for this tooth. So he just removes the remaining decay, place paste and amalgam filling. Then follow up. In the next 3 years, the tooth is symptomatic and responds to pulp test. At the same time, the X-ray image shows a normal periapical picture. What does discovery means? It reminds us that vital pulp tissue may be found, may be kept in teeth with periapical infection. So it's not a new site, not a new veil, right? And vital pulp surgery may be successful. But definitely, two birds predict the prognosis for similar tests solely based on outcome of a single case. So the dentist carry out a prospective clinic study, and 8 teeth with periapical lesion and containing vital tissue were recruited from 11 to 18 years old patients. Of the 18 teeth, 4 teeth were normal to pulp test, whereas the other 4 abnormal. Then, the directed pulp therapy and the directed pulp keeping conducted. After that, just follow up. How about the result? The last figure is reports that for tooth treated with indirect pulp keeping or indirect pulp surgery at 6 months, the teeth were vital and the periapical picture normal. How about direct pulp keeping? Let's say, also at 6 months, the teeth responds to pulp test and present a normal periapical picture. And the result showed all the teeth present clinical evidence of vital pulp tissue and periapical tissue repair. And all the teeth were accepted medical. Based on the result, it concludes that tooth with a periapical lesion may contain white pulp. Direct and indirect pulp keeping were effective. And based on the result and the conclusion, is a stage where there's white light, the hope of recovery. Remember this sentence. What's the clinical significance for us? It means
Anh
as
nói
long
bằng
as
tiền đâu.
there was widely the wider palm third having attempt to tease either with erodible palpitis or even with apical periodontitis. We should know it's published in 1967. So that's almost 6 years, right? But it's not well known. And it's not well accepted by all of the dentists. Fortunately again, many research or many dentists kept trying in this regard. So many evidence accumulated. Now, let me show you one more case with more detail and to help us to understand what that means. Where there is whitelet, there's hope of recovery. Because there are more details. This is a 12 years, 18 months old girl, and she complained swelling of right cheek and moderate pain in area of mandibular right premolars. And clinical examination we could find actually the swelling here just on the back side, apical to the premolar, And we also could find a round depression at the center of the occlusal surface. It's a typical appearance of broken or central cusp, right? And the radiograph shows the large radiolucence. That's large radiolucence. And the CBCT match confirms the result. It also shows a significant size of bone lesion, right? And the root immature. And look at this image, you see. The bone lesion affect all the aspects of the around all the surface. So also it's reasonable to make the diagnosis and also easy. It's apical periodontitis, right? And for young permanent teeth, without using local anesthesia, the pulp chip exposed and remove the necrosis by irrigation, then explore the root canal with the file, and the patient report discomfort, report pain, and the bleeding was observed. So the whitelet was established, right? Then the vital palm search attempt in one visit. This is the X-ray just immediately after the operation. And at 5 months and 9 months follow-up X-ray shows the radiolucence decreased and the root continue to develop. It's very obvious, right? And 15 months after the operation, we could say the bone lesion resolved completely. And the CBCT match confirmed either. You remember? We should see this image. We say the bone lesion around the root surface healed completely. Can you remember this picture just before the treatment? Compare this to image, we found the bone lesion disappear, healed completely, right? Then to remove the crown restoration, we could observe the kissel barrier and then permanent restoration was done. This case shows vital pump syrup also achieved complete success for young permanentes, even with large apical radiolucency, right? It's a very large radiolucency. It's a very large apical layer, bone layer. Actually, the evidence, more and more evidence accumulated. Finally, the American Association of Endodontics accepted. So, is the written that position statement on vital pulp syrup published in 2021 that it said the viewpoint that vital pulp syrup is only indicated for cases with clinical irreversible being challenged. And the end of the summary is written said that a pre-treatment diagnosis of irreversible pulpitis is not necessarily the indication for pulpectomy. As more conservative treatment could be considered. So, now, both literature evidence and institutions support vital pulp syrup may be indicated for the teeth with irreversible pulpitis or even with apical radiolucency. So, it's reasonable for us to attempt vital pulp syrup for teeth even with large radiolucency. We could do our best, do everything we could do to keep vigilant, especially for young permanentes, right? Then the next question is how to perform white pulp syrup for teeth with irreversible pulpitis or apical proctitis. How to perform? Actually, this is the most frequent question asked during I gave the lecture in China. How to do? When a patient came to your clinic, of course, we should do the diagnosis first, right? Even the diagnosis with irreversible pulpitis or even apical proctitis was made, you should have a concern. You should remember that we should clarify if there any vital pulp tissue in that tooth, or if the vital pulp syrup can be attached for that tooth. Here I want to emphasize again, irreversible or reversible pulpitis is clinical assessment for pulp status. Clinical assessment, and it cannot tell how far the inflammatory has gone through, and cannot tell whether the pulpitis reversible or irreversible. So, as for why there is vital pulp tissue in root canal of teeth with periapical infection. I think a lot of guys are very confused, right? Actually, a lot of investigation has been conducted. A lot of investigation. And it's found that bacterial infection of root canal induce bone destruction from distance rather from direct effect of bacteria on periapical tissue. From a distance rather from direct effect. And more important, the bone resorption can take place long before the pulp totally negative. You may wonder, how did it happen? I suppose that the necrosis and infection in coronal pulp tissue trigger release of pro-inflammatory mediators, which may diffuse through the radicular white tissue to cause periapical change. Now it's reasonable. It's easy to understand why the white pulp tissue in root canal of the teeth with erased apical peduncules, right? So, for the teeth, we should clarify. Of course, it's not all the teeth with periapical lesion white tissue could be found. So in the clinic, we should first clarify whether there is white pulp tissue in the affected teeth. How to do? The same question. How to do? Actually, we have many ways to do pulp test to evaluate the whitelet of the tooth. One, the first one, the most often used one, pulp sensitivity test, such cold test, electric pulp test, is still the most frequently used way to evaluate the whitelet, right? But as we all know, it gives high incidence of both positive and negative result. So it should be verified by another way. In clinic, we could do some excavation without using local anesthetic. I may do a little, but we should. When we use the excavation, it must be with caution. Why? Because if the white pulp tissue remain in the root canal, the patient would feel pain, right? If for a child and he's anxious, what happened? It's negative his cooperation, right? It's difficult for us to handle. So we should use it with caution. And if for tooth pulp exposed, then direct observation would be the best way. Of course, microscope recommended because it provides us with the most effective information for evaluating the pulp stages. Its form, its color, and the bleeding, right? The most effective way. But what if no microscope available in your dental clinic? Or what if the white pulp tissue is located at the middle part or the third part of the root canal? What can we do to do the evaluate whitelet? So we can just explore the root canal with file, simply and gently, right? If there are white pulp tissue in the root canal, the patient would feel discomfort, even the local anesthetic being used. And for the dentist, we could feel there are some soft tissue in the root canal, just by your finger feeling. You can feel it. So, in clinic, we should use every known ways to establish white lid, all the ways, all together, to establish the white lid. And once the white lid is established, what would you do for the next step? What would you do? For the next step, we should figure out which of the following procedure suitable for the affected tooth. Which procedure? Actually, all the procedures have been reported to be successful for tooth with irreversible pulpitis or apical parodontitis. All the procedure. But which is best? Most studies support partial pulpotomy or pulpotomy. And in terms of partial pulpotomy and pulpotomy, which is better? It's also investigated. Let me show you the research. In this research is found the clinical and X-ray success rate of pulpotomy, but how than partial pulpotomy? Significantly, right? Why? Actually, it's reasonable, it's easy to understand, because pulpotomy removes more inflammatory pulp tissue than partial pulpotomy. Then we could say, the more pulp removed, the better for healing. It's true that for sometimes, but it's not definitely true. Why? Why? Because we should remind you that this result is about fully developed molars. It's fully developed molars, right? And for young permanent teeth, because I cannot exactly introduce myself, I'm a pediatric dentist with over 30 years experience. I will do a lot of endodontic about immature permanent teeth. So, for young permanent teeth, they have stronger capacity of regenerative and repair, right? So in clinical practice, we may work out the plane based on the depth of caries, the location of the white pulp tissue at the root canal, root development, and clinic subtemporal. Up to now, we talk all the procedures are traditional ways for vital pulp therapy, right? In fact, the most frequently used way for vital pulp therapy is modified pulpotomy. Modified pulpotomy. You may ask, what's the difference between modified pulpotomy and pulpotomy? Just like the picture shows, after all the lesion tissue removed, after the pulp exposed, no matter where the vital pulp tissue located, just leave it alone. What we do just irrigation. No vital pulp tissue removed. No vital pulp tissue removed. just irrigation. In this case, the white pulp tissue was observed just 1 to 2, 3 millimeter beyond the exposure site. So we did irrigation. And for this case, the pulp tissue is in the middle part of the root canal. We also do irrigation. No white pulp tissue removed, even though it's inflammatory. We just keep it. And for this one, is the white pulp tissue located at third part of the root canal. And the same procedure, just irrigation. So all the procedure could be used in clinic for choose with pulp exposed and with irreversible pulpitis or apical pancreatitis. All the ways. And the modified pulpotomy is the most frequently used way in our clinic. It's more conservative, right? And for the next step, I'm seeing those for teeth with normal pulp or reversible pulpitis, such as irrigation, anesthesia, pulp capping, or cranial sealing. And one of the most frequently asked questions is, which solution recommended for irrigation and hemostasis? Which one? Sodium hypochlorite, right? Because of its capability of dissolution of necro tissue and antibacterial effects. But it's with wide range of recommended concentration, right? A wide range. And as we all know, the higher the concentration, the stronger the toxicity. For white pulp therapy for teeth with inflammatory pulp tissue, we should balance the infection and toxicity, right? Toxicity is difficult for me to spell. Toxicity should balance. So 2.5% is recommended. It's recommended by the research. This is most frequently asked question. And the next, or another most frequently asked question is, which material is applied for pulp capping? We all know pulp capping materials mainly include two categories, right? The ceramic calcium hydroxide preparation. Then which is better? It's all asked. Which one we should use? Actually, as more recent research support bioceramic, right? Because it may induce thick calcified barrier, and it have better ability of seal and more stable, right? But it's also report for calcium hydroxide preparation with proper sealing, that success rate showed no significant difference compared to bioceramic. So both of them are good material. For bioceramic, it's expensive. It's the same in your country. It's more expensive, right? So we can choose one based on the clinical situation, right? Now, just let me show you the entire process of vital pulp surgery for the teeth with irreversible pulpitis or apical proctitis. I just show the picture, right? The same one. This is a 13 years old girl and experienced pain just when biting or curdling. And clinical examination, we found there's extensive decay. Now, as the X-ray shows, the root fully developed, and the pulp involved, right? And the radiolosis and the apical of the mesial root. So, is our diagnosis with apical proctitis, right? Then we just saw, if there any possible is that some vital pulp tissue remained in the root canal of the teeth. How to evaluate? How to establish the vitality for this tooth? Because it's pulp involved, apparently, right? So with local anesthetic and isolate with rub down, all decayed dentin removed and the chamber exposed, then vital pulp tissue observed directly. So the vitality established, right? Then vital pulp search was attempted. Which procedure? Because it's a fully development molar, so we choose pulpotomy. Remove the tissue, the pulp tissue to the root canal face and copial irrigation with sodium hypochlorite and homeostasis. It's a chill homeostasis. So then just the ceramic is placed on the surface and the chamber and sealed. And finally we use stainless steel crown. We use a lot of stainless steel crown in our clinic, in the Department of Pediatric Dentistry. This is for one visit pulpotomy for vital pulp therapy. Now let's back to the case. Just show you in the beginning of the lecture, remember? Now let's to the question. I thought you should have new answer, right? And for this, we should solve the things that is there any possible to do the vital pulp surgery? So, this case is in 2015, almost 10 years, more than 10 years, right? We just isolate and also use local anesthetic and the chamber exposed. We also see pulse and bleeding. After irrigation, we exploit the canal gently with a file. Actually, we use a lot of exploit. Even the microscope is available in our clinic now, but the most often used way is still exploration. So the patient reports pain. So just the same way we talk about to do copial irrigation with Then we put calcium hydroxide preparation as a dressing and the seal. That's what puppetry is done in 2 visits. Why? Because they have gingival abscess, right? Remember? Then 2 weeks later, the boy came back and the tooth accepted magic and the gingival abscess disappeared. Then we isolate the tooth again, remove the restoration and the dressing. I could say the root surface, the surface, we could say the hair, maybe we could say, oh my god, some good necklaces here. So just remove the necklaces and put the material is still calcium hydroxide preparation because it's 10 years ago, right? Then we make the base with glass enamel, cement, and do the final restoration with compound, then do the follow-up. The tooth was followed up for almost, I can say, 70 months. For 70 months, the tooth asymptomatic, and the roots continue to develop either. And this is the same tooth, and this is the same tooth on the contralateral. We could say the root almost develop at the same rate and the same extent, right? So, this is the color of the tooth is very satisfied, no change. Actually, we have a lot of more interesting cases. This is another case. Let me say, this 8-year-old girl and just spontaneous pain in left lower posterior region for 1 month. And clinical examination, we just could find a black spot on the occlusal surface. Also, there on the distal, the gingival abscess right yet, but the X-ray shoot and large radiographies. Just the distal. And I want to remind you, just look at the germ of the second molar. Actually, it's pushed away distal because the lesion. I also want to notice the time. It's 2020. Remember what happened at that time? Pandemic, right? So it's really difficult for the patient to visit the dentist. And the more difficult is the patient is not in our city. So makes the visit more difficult. So it's the first time we just remove all the lesion tissue. You may find this in the second picture. You may find the color a little dark, right? Then we remove, expose the champ. We did notice the white pulp tissue in the champ, but its form and its color is totally different from the normal pulp tissue. Totally different. It's dark. Even then, we attempt white pulp surgery also. Just remove the pulp tissue into the root canal face, and it's difficult for us to achieve hemostasis. Even after copious irrigation with sodium hypochlorite solution. Then, what do? We just put calcium hydroxide preparation as the dress and the seal, and make the appointment. 1.5 months later, the girl came back with his money. And the truth is symptomatic. So we repeat the procedure just to talk about in the last case, and restore it with stainless steel crown. And this X-ray she take it is how to say city and sent to me because it's really difficult to come to our city. I mean, what do you say? The delusions disappear, and the second, the molar came back, right? You see, you can compare, right? And I'll show you the last case, more interesting. This is a 6-year-old boy, and his left incisor, the upper left incisor, was during swimming. So the teeth was soaked in swimming pool for 40 minutes, and then put it in mineral water. It was replenished 2 hours after trauma. There's 2 weeks later, there are gingival abscess on the labial side of the tooth. Then it was the champ exposed, and the bleeding was noticed. We just do the same procedure. The 4 weeks later, and 4 weeks after the operation, and 6 weeks after the trauma, the patient came back, no found the gingival abscess and disappeared. And till up to now, it followed for 6 years. For 6 years, we could say the root completely formed. And we also could say the periodontal ligament membrane, right, is very clear. So I will show you a lot of evidence that well, that's whitelage, that's hope of recovery. So I want to remind you, just keep it in your mind and do whatever and do everything you can do to keep the whitelage. And how? Maybe 3 key steps: infection control, pump keeping, and complete corona sealing. But we should emphasize that preoperative procedures was the only variable with a success rate. So we should emphasize preoperative informed and consent, and the postoperative follow-up is necessary. Now, finally, I see one more quote about FDI Congress, a World Dental Congress. It will be held in September, just next month, 9 to 12 in Shanghai. And I came from Shanghai. So welcome to Shanghai. That's all for today. Thank you.
Thank you. Thank you very much, Professor Wang Jun, with a very interesting, very nice presentation. So now, any question? Các bạn có câu hỏi gì không? Thì cô cũng đã quá một chút giờ rồi. Các bạn trong
Because it's so easy, so no question.
Xin mời bạn.
Alo. Vâng, em là một bác sĩ răng trẻ em và em cũng có tra cứu trực tiếp một số ca. Thì em có một câu hỏi như sau. Thứ nhất là cô có bảo là cái kiểm tra tủy sống bằng cái file K đấy, thì em muốn hỏi là cái file K số bao nhiêu và khi mà mình chọc vào thế nó sợ là chết tủy luôn. Và cái thứ hai đó là sau khi mà che tủy trực tiếp xong thì ví dụ ngày hôm sau bệnh nhân bị đau luôn á, thì cái đấy có đồng nghĩa với việc là mình che tủy trực tiếp thất bại. Em xin.
You have two questions.
Yeah.
He is a pediatric dentist, and he asked two questions. The first one is when you use the case file.
Case file, right? Case file, yeah.
So which tools do you look and how to practice it? And the second question that when you do your during practicing, the patient has pain in this way, is it means that you have any problem of during practicing?
Yeah, thank you for your question. And the first one is, it would be harmful to do the deploy, right? With the key file. Yeah, you just do it, you just touch it, not go through it, right? You just can feel. So I don't think it's maybe a little, but you can ignore it. Yeah. And for the second question is, have some pain after the pulpotomy. So do you think this is a problem with the pulpotomy? Actually, that's certain. How to say? They're laughing because I can't express myself freely in English, right? Because it seldom happen for patients. You should do copious irrigation. You should release all the pressure. Yeah, so it's good I think so.
Thì câu hỏi đầu tiên của bạn là khi dùng cao phai thì có gây ra các cái có hại gì cho mô thủy hay không? Thì cô nói là trên thực tế thì chắc là nó có, đấy là một cái tác động vật lý, nhưng mà tuy nhiên cái tác động này rất là nhỏ và nó không gây ra ảnh hưởng đến quá trình điều trị. And which size of K5 do you use?
Just keep out.
Just K5, tức là các bạn có thể sử dụng bất cứ một cái K5 nào, không cần phải là số bao nhiêu. Câu hỏi thứ hai là bạn nói rằng là khi chúng ta thực hiện cái việc mà che tủy trực tiếp ở trong rồi lấy tủy buồng hay che tủy trực tiếp mà bệnh nhân có đau trong vòng 24 tiếng thì đấy có phải là dấu hiệu của thất bại, hay chúng ta có bất cứ một cái sai lầm nào không? Thì cô cũng nói rằng là cô cũng rất là bối rối với câu hỏi này, bởi vì là thông thường chúng ta sẽ sử dụng cái bơm rửa rất là sạch, và cái đau ở đây thì đây tôi nói thêm một tí nhé. Cái đau ở đây nó là do các yếu tố gây viêm và mô viêm, và khi chúng ta làm sạch thì nó không còn các nguyên nhân gây viêm nữa, không còn các nguyên nhân gây đau nữa. Do vậy là đối với liệu pháp tủy sống, chúng ta lấy đi toàn bộ các cái mô thủy đã bị viêm và giữ lại mô thủy lành, thì các yếu tố kích thích đau không còn nữa.
Thank you. Thank you for your information. Thank you for your help.
Sau đây xin mời giáo sư Dung lên trang chủ chương.
So it's for me, right?